Okay, so my talk today is on injectable lipid therapy, which is basically PCSK9 inhibitors. Indications, patient selection, and choosing right agents. The only injectable lipid therapy now available, at least, are PCSK9 inhibitors. Let me start with the first most basic question. Why do we need a new lipid lowering drug? Because we have statins, which are powerful anti-lipid drugs, huge data behind them on cardiovascular endpoints. So why do we need that? Number one is that LDL cholesterol is no more considered as a risk factor for coronary artery disease. LDL cholesterol is now considered as a causal factor, not really a risk factor. And when you reduce LDL cholesterol, it has been found that the benefits go down and down. Whatever LDL cholesterol, the benefits are there without reaching a plateau. Right up to 30, there is a, right up to 30, there are benefits now. Even less than 30, it has been shown that there are benefits with lipid lowering. Now, it is not only the magnitude of LDL reduction or elevation, if you look at the risk, it is also the cumulative duration of exposure. So maybe the most effective strategy for reducing lipid-related risk is early, not only lowering of LD, but early lowering of LDL and maintaining these low levels of LDL for a long duration. Now, if you look at a very high-risk patient, the present guideline says LDL should be less than minus 55. When you give a high-intensity statin, you can expect a reduction of 50%. So if the baseline LDL is above 110, high-intensity statin is not going to be enough. And you require another drug in these patients, even without waiting for the statins to state effect. And all said and done, you may say statin have no side effects, the muscle symptoms are mainly nocebo effect, functional, etc., etc. But all said and done, many people do not tolerate high-intensity statin, and so compliance is a big problem. Moreover, even when the LDL is less than 55, there is a residual risk. There are a lot of factors which contribute to residual risk, but maybe the most two important are HDL and triglyceride. Unfortunately, we don't have any HDL increasing drugs which have shown to reduce vascular events. We don't have any triglyceride lowering drugs with a similar history, except of course icosapent and ethyl. So there also the recommendation is reduce LDL further. Well, a word about plasma LDL regulation before I go further. Now, the most important organ which removes the plasma LDL is the liver. And the liver removes LDL by the LDL receptors. There are LDL receptors on the cell surface which attaches the LDL. The complex gets internalized and the LDL is degenerated. So the LDL attaches to the receptor, the formed complex is internalized, and the LDL detaches from the LDL receptor and is degenerated by the lysosomes. In other words, plasma LDL is dependent upon LDL receptor density. The more LDL receptor is there, the less will be the plasma LDL cholesterol. So our aim in treating LDL will be to make sure that the LDL receptor density is high. PCSK9 unfortunately binds to the LDL receptor, and when it binds to the LDL receptor, not only the LDL, but the LDL receptor is also degenerated. Or in other words, PCSK9 acts as a chaperone, leading the LDL receptors to its death, which means that there are reduced LDL receptors on the hepatic surface. PCSK9 increases LDL levels, or PCSK9 inhibitors, on the other hand, reduce LDL. To put it pictorially, this is the LDL receptor, and this is PCSK9. This combination, you can see, goes into the cell, and the whole thing is destroyed. No more LDL receptors. You give a monoclonal antibody, blocks the LDL receptor, this combination, and so you can see the LDL receptor is not degenerated, it comes back to the cell surface. So the LDL receptor number increases, LDL level comes down. You give inclisiran, which is a small interfering RNA which interferes with the messenger RNA which encodes for PCSK9. PCSK9 production is reduced, and so naturally you have more LDL receptors. There is strong genetic support also, because when there is loss of function mutations, LDL comes down and there is reduced risk. The other way, gain of function mutations, LDL level goes up, increased coronary artery disease. If you look at monogenetic familiar hypercholesterolemias, there are mainly 4 proteins that are involved. LDL receptor is the most common, ApoB, LDL receptor adapter protein, and PCSK9. So that is involved in genetic hyperlipidemias also. Now, when you combine PCSK9 inhibitor with a statin, there is no question, the first line treatment in LDL reduction, but there is a counter-regulatory effect that limits the ability to lower LDL, because unfortunately statins stimulate the production of PCSK9, which in turn reduces LDL receptor activity. In other words, this combination of PCSK9 inhibitor with statin is a good synergistic combination. Okay, there are 2 types of PCSK9 inhibitors. One is the antibodies, monoclonal antibodies, evolocumab and alirocumab, which targets the circulating PCSK9. Whereas inclisiran is a small interfering RNA which targets the hepatic PCSK9 synthesis. It is a double-stranded small interfering RNA which targets the messenger RNA that codes for the production of PCSK9 specifically in the liver. This is the dosage recommendation. First, you give 1 dose after 3 months and then every 6 months, twice yearly. It is given by the healthcare professional in a single pre-filled syringe, no refrigeration required, and the dose is 284 milligram as a single subcutaneous dose. Now, both inclisiran and monoclonal antibodies, both of them also reduce lipoprotein little. There are few other drugs, only few other drugs which reduce lipoprotein little. Now, if you look at the evidence, there have been several studies, but the 3 randomized studies, one of them in heterozygous familial hyperlipidemia, yet another with ASCVD, and the third with ASCVD or ASCVD risk equivalence, and all of them LDL reduced by 50%. But does this LDL reduction translate into cardiovascular event rate reduction? We still do not have any data. We have only data that it reduces LDL cholesterol. For that, we will have to wait with the 2 major trials, Orion 4 and Victorian 2 Prevent, to know whether the LDL cholesterol reduction will be translated to cardiovascular outcome reduction. As at present, the European Medical Agency has approved it for primary hypercholesterolemia or mixed lipidemia on maximally tolerated statin therapy. FDA has approved it for treatment of adults with clinical ASCVD or heterozygous familial hyperlipidemia on maximally tolerated statin, and also in primary hyperlipidemia. The advantages of inclisiran are that there is prolonged lowering, as I said, persistent lowering, only twice a year recommendation injection, very good safety profile, infrequent dosing is an attractive option to overcome non-adherence, and it minimizes the risk of poor adherence and improper drug administration because the healthcare professional is giving the injection. So you don't have to worry about that. Well, huge number of trials going on, but as I said, what we are waiting for is probably the Orion 4 and the Victorian 2 Prevent. Okay, let us look at where you give these drugs, PCSK9 inhibitors, whether it is inclisiran or monoclonal antibodies. We will start for secondary prevention, ASCVD. You can divide into 2 groups. One is not at very high risk and the other at very high risk. The very high risk groups are those with a history of multiple major ASCD events, or one major ASCD event and multiple high risk conditions. These are the high risk conditions. Almost all of our patients will be having at least one of them. In other words, most of our patients are very high risk ASCD events. And we have data that in this group of patients, there is benefit with high dose statin, ezetimibe, evolocumab, and alirocumab. We also have data in primary severe hypercholesterolemia, which is LDL more than 190. Again, with this group of patients, ezetimibe and PCSK9 inhibitors. So if you divide the group of patients into secondary prevention, primary prevention, primary hypercholesterolemia, that is LDL more than 190, diabetes, without diabetes. In very high risk individuals, the guideline says LDL less than 55. And in those cases, you are justified in giving statin, of course, plus ezetimibe, and then PCSK9 inhibitors, or you can give bempedoic acid or inclisiran. So all these gets a class 2A, class 2B recommendation. Patients who are not at very high risk, the guideline says 70 milligram per deciliter. There, again, you give statin, ezetimibe, either PCSK9 inhibitors or inclisiran and bempedoic acids. In patients who do not have, without clinical ASCVD, that is primary prophylaxis, LDL less than 100, but LDL baseline more than 190, there is still some recommendation for PCSK9 inhibitors. PCSK9 inhibitors can be either monoclonal antibodies or inclisiran. But in primary prophylaxis where the LDL is less than 190, there is no indication. The indication is only for statin plus ezetimibe. Now there is data with respect to LDL lowering in acute coronary syndrome. If you look at this chart, very interesting chart with evolocumab, 420 milligram evolocumab given in NSTEMI, you can see by day 1, just day 1, already LDL has started coming down. And by day 1 week, day 3, you can see that the LDL cholesterol is already 55, which means you have already reached the target for a very high risk individual just by day 3. Very interesting data. Whether that will translate into clinical event rate, we will have to wait and see. Two-thirds were being discharged with LDL cholesterol reaching the recommended goals. With this data, the European Society of Cardiology have given a proposed algorithm, not a recommended algorithm. This is only a proposed algorithm, where they say that all ACS patients can be given high-intensity statin plus ezetimibe. And then, if the patient has other risk factors, especially additional high risk factors, you are justified even in giving a PCSK9 inhibitor in a patient with an acute coronary syndrome. This has not yet come in guideline. So to conclude, I would say the recommendations for PCSK9 inhibitors will first go to class 1 indication is secondary prevention, very high risk patients. Primary prevention, familial hyperlipidemia with another major risk factor. So these are the two real class 1 indications. High risk secondary prevention, familial hyperlipidemia with another major risk factor for primary prevention. Less weaker indications, class 2B indications, will be for primary prevention but without FH, and when statin is not tolerated. These are 2B indications. So I would say the primary indication, class 1 indication, is 1 secondary prevention, 2nd primary prevention in a patient with familial hyperlipidemia, and 1 other risk factor. I think I'll conclude here, and thank you very much.
Thank you, Unni. I mean, as important as the LDL level, possibly LDL years or cholesterol years are important. I think amongst us, Jabir has the most experience with the inclisiran. I think he's involved in all the inclisiran trial. You can just have a comment on your experience with inclisiran. We don't have that much of it.
Sir, the most important thing is the tolerance to therapy. No adverse effects. Only some minor injection site abnormalities, and the cholesterol comes down. Though the data shows that there is a reduction in the LDL cholesterol by around 3 months. The reduction in the LDL cholesterol to the target level or low is little delayed in the inclisiran group when compared to the PCSK9 inhibitor. We don't have direct comparison data, but PCSK9, immediately the cholesterol level drops. Sir was showing that at 3 days it drops down. But here it may take 15 days or so, but whatever patients whom we have given open label, when we checked, it comes down by 1 month significantly. The reduction, and 90% of the people, they reaches the goal. And it's a sustained one. So another important concept that is coming up is lipid variability. So if you give inclisiran or PCSK9 inhibitors, the lipid variability will be much less. Just like blood sugar variability, just like BP variability, the new concept of lipid variability is coming up. That can be significantly reduced with the use of inclisiran.
It is understandable, Jabir. It is understandable why inclisiran takes longer time, because it prevents the synthesis. So whatever PCSK9 is there in the circulation will continue to act, whereas monoclonal antibodies immediately block the PCSK9.
And when it is synthesized, that is why, sir, there is some escape also. Even after complete use of inclisiran, the PCSK9 level is around 80% less. it's some 15 to 20% PCSK9 is still there in the circulation.
Thank you, sir.
Thank you.